Good afternoon, everyone. Thank you for attending this session. We'll go over the test case titled Creation of a Patient-Facing Mobile App for a Stress Urinary Incontinence Surgery Registry. My name is Keonde Urban. I'm one of the research managers at NEST. I will be moderating this panel. I'll be introducing the investigational team, as well as go over test case relevance in the medical device ecosystem. So we have Dr. Bilal Chatai, Associate Professor of Urology and an Associate Professor of Urology and Obstetrics and Gynecology at Weill Cornell Medicine. We have Ann Hammer, Network of Experts Coordinator, Office of Strategic Partnerships and Technology Innovation of the CDRH at the FDA. We have Dr. Art Sadrakian, who's a Professor of Population Health Sciences at Weill Cornell Medicine, as well as a Director for the Institute for Health Technologies and Interventions and Medical Device Epidemiology Networks Coordinating Science and Infrastructure Center, MD EpiNet, as well as NESTcc Governing Committee member. And we also have Dr. Vahan Samoyan, who's the lead instructor for MD EpiNet Hive. This test case focused on PGD, patient-generated health data, and also a prospective and retrospective registry. This project was roughly about 12 months, which was completed this past July. This disease area of this project is in urology, and the technology of interest is a mobile health for surgical mesh via mobile app, part of the Women's Health CRN, which this is considered a Class 2 device. The purpose of my discussion is to go over two main points: the test case relevance, not only to NEST, but as well as the ecosystem, and to discuss NEST's role throughout the life of the project. The criteria for this test case, which made it a very useful study, was that it combines both the use of registry data and the development of mobile health technology for a prospective study. And the importance to the ecosystem is that this test case does provide a unique opportunity to truly understand our research networks at NEST and can truly support studies that focus on a specific demographic group with that patient-centered focus and input. As far as the NEST role, there were a few things that were pivotal in getting this project from start to finish. Obviously, coordinating engagement between the project team to ensure that patient-reported data capture is improved, and also developing deliverables with the project team and answering key questions throughout the test case, and so that we're able to provide a streamlined efforts for completion of milestones and reporting requirements. And the final point to discuss is, establishing regular review and feedback opportunities among all participating sites and institutions, stakeholders, which results in significant improvements to the app itself, and identification of any bugs or issues that otherwise may not have been found. And with that, I'll turn it over to Dr. Art Sadrakian and team.
Thank you very much, Keonde. It's really a pleasure to partner with NEST and showcase a really important product today. And I just wanted to highlight the partnership we have with NEST Coordinating Center as Medical Device Epidemiology Network, which is an organization and growing as a global public-private partnership that is dedicated to the discipline of medical device epidemiology and outcomes research. We have a vision to have a leader in development of innovative approaches and generating evidence throughout medical device lifecycle. And our mission is to really focus on novel methods, infrastructure, and partnerships to advance use of real-world data for NEST and in collaboration and partnership under the umbrella of NEST Coordinating Center. We have now chapters internationally that helps us also to leverage real-world data from multiple countries. Next slide. The key infrastructure units that MD-EpiNet has been invested in are called coordinated registry networks. And we have 12 national and 3 international coordinated registry networks. 3 of them orthopedic devices, vascular devices, which is called Vision, and women's health technologies devices will be featured in a series that NEST Coordinating Center is presenting today. And we will be focusing on women's health coordinated registry network contribution with the development of patient-facing mobile application to advance the women's health. Our collaboration involved urology leadership from Bilal Chatgai, technology development for Hans Simonian, who is lead architect of MD-EpiNet Hive, and coordination from MD-EpiNet Center and from Department of Urology from Suveksha Ariel and RHO. I'll pass on to my friend and colleague Bilal Chatgai to describe the process and also clinical context for developing the mobile application.
Well, thank you for the opportunity to speak about this exciting project. So just to build some background on an introduction on stress urinary incontinence. So stress urinary incontinence is the involuntary loss of urine with physical exertion. It occurs in approximately 1 in 3 women above the age of 45. And the annual cost is over $19 billion in 2000. So obviously far more currently. The current guidelines for stress incontinence include observation, pelvic floor exercises, non-surgical options such as a pessary, as well as surgical intervention, which we'll go into more detail. The surgical treatments include bulking agents, which could be made of hydroxyapatite or various agents. The goal of these bulking agents is to strengthen the urethra for its intrinsic weakness. They've had moderate success rates over the years. Copal suspension, which we refer as traditional repairs, which is the Burt's copal suspension, as well as the MMK repair, and sling procedures, which include autologous fascial slings, as well as mid-urethral slings, which is the gold standard. Next slide. So our focus here is to talk about our current gold standard for stress incontinence, which is the mid-urethral sling. It's demonstrated less pain, shorter hospitalizations, faster recovery, reduced cost. It's used by over 99% of members of the American Urogynecology Society. Short-term safety and effectiveness has been well established with short-term data, including with 1-year outcomes. But there have been limited studies on long-term outcomes. Currently, there's over 70,000 federal lawsuits against transvaginal mesh products. Next slide. If we look at the trend of mid-urethral slings over time, this is a study that we published in 2013, which basically shows that mid-urethral slings from about 2000 likely up until present have become the dominant procedure, while both periurethral bulking agents and traditional repairs have essentially fallen out of favor. So when it comes to mid-urethral slings, we know short-term safety and efficacy. Our big gap in our data is long-term patient-reported outcomes following these sling procedures. So this is our study looking at the long-term safety of sling mesh implants for stress incontinence. We looked at New York State residents undergoing surgery for stress incontinence between 2008 and 2016. We used both ICD-9 and CPT codes to identify cases of slings alone, slings with abdominal prolapse repair, and slings with transvaginal prolapse repair. Those who underwent concurrent transvaginal mesh repairs were excluded, and those with previous slings or previous transvaginal operations were excluded back to 1995. Next slide. We found that the mean age was about 53 years old. The mean follow-up was about 4.8 years. Most of the operations that were done predominantly were isolated slings, so about 77%. 20% were done with transvaginal repair, and 3% were done with abdominal repairs. The risks at 7 years post-surgery included a 3.7% risk of erosion, where the highest risk came from lower age, lower volume facilities, and a history of hysterectomy. The risk of any reoperation was with a concurrent abdominal procedure with sling, a previous hysterectomy, and a concurrent diagnosis of depression. Next slide. From this study, and I mean in general from the literature, what we need are patient-reported outcomes, because this helps facilitate proper assessment of benefits and risks of these devices using real-world data. We need something that is user-friendly, secure, robust, patient-facing, that can enable data collection that can be integrated within registries. This can facilitate the monitoring of long-term critical assessment of efficacy, safety, as well as patient satisfaction with these devices. And this needs to be integrated with physician data collection to get long-term outcomes for women's health and stress incontinence. Okay, here we'll have Vahan take over and discuss the app development and design.
Hello, and thank you for this opportunity to present you the technologies that we are developing for this cause. So we have chosen the Hive platform, which is a legacy data platform for FDA, to implement this registry. And this slide, we are demonstrating what Hive does for this cause. So it allows you to collect the patient-reported outcomes and doctors and coordinators' clinical input into data entry application. It's a web application which is available through web protocols. Data survey structures, which are previously downloaded into the system by registry developers, are downloaded to the web application, and then patients and the doctors can enter the information. All information goes through data validation engine, which validates data types, data field constraints, ranges limitation, vocabulary limitation, all different types of constraints. And then through the variable, it puts into the data ingestion engine, which does additional validation. So no wrong data, no incomplete records are able to go to the database. And then once everything passes, it goes to the Hive Honeycomb database infrastructure. And then a researcher, MD-EpiNet researcher, can use data request APIs, and after permissioning checks in the data provision engine, they can either download the data as is, or they can run a computation using Hive's analytics score and then download the outcomes of the computation. And algorithms can be developed by registry developers, or existing algorithms can be integrated into data analytics score. So it's an end-to-end solution from data entry by patients and doctors, and data analysis and data use by the researcher. Everything in Hive is covered by the firewall, which is represented in this reddish ring. For the data entry part, where the patients are entering, first they have to have provided their credentials, logging in, and then they download the app survey structure, they fill in the survey, and the data goes back. The same with doctors, it's a three-stage process. You log in, you get the data forms, you fill the data forms, data goes in. And then it also allows us to connect to non-Hive managed registries by either ingesting the data from non-Hive managed registries, doing the harmonization, standardization of fields, and then putting into Hive Honeycomb data infrastructure, which is FAIR and FHIR. FAIR means that it's a shareable, identifiable records, and FHIR is the transaction protocol, which is used for real-world data communications. And then similarly, Hive can output its data structures for consumption by the other registries, which are not managed by Hive. So the app that was designed is not just about entering the values and validating them. They are coordinated processes, triggers, and notifications that go around, so timed action is required by patients and by doctors. On the left column here, you can see the types of surveys that patients are conducting. This would be demographics, preoperative survey before the index procedure, and the time triggers will be available at 6 weeks for postoperative follow-up survey, 1 year, 2 years, and 3 years by the patient. On the right side, which is driven by the doctors, clinicians, or the coordinator, there are certain surveys like perioperative questionnaire, post-index, and then years follow-ups. And then these processes are interconnected. So the moment the patient fills in, for example, the 1-year follow-up survey, doctor will be notified and invited with the link, filling in their form appropriate to this time point. So there are time points on the vertical delays, and there are triggers going horizontally. Now I will demonstrate you live demo. So at the point when a patient or a doctor is invited to the portal, they have a specific link, which is survey.mdepinet.not/register. They come, and for the facility, I already filled in a fake patient in this case. So let's say it's a Joy Doe, and then a password which I entered, and the patient has a consent body. At the end, they have a chance to sign in. Please register. By the way, I'm offered a chance to save the password. So from this particular device, it will be easy for next time for me to come and do operations. So in this case, they have 2 surveys available. One is patient experience survey, and the second is patient stress urinary incontinence survey. That's what I'm choosing right now. So here we have, first I can select the facility, and then I can select a doctor. In this case, I'm going to select a doctor, which is the test doctor, and type my name. Next. Now I can enter my birth date and answer certain questions. I can put my height, weight, and then surgery date, let's say it was 16. If I say yes, then there are additional questions. If I say no, there are no additional questions. For the smoking status, let's say this is the one. And then I'm going to just answer the questions. Obviously, in real time, people have a chance to answer, think about questions a little bit. So now, and then there are multiple selection points. Sometimes I can select not a single variable, but multiple. In those cases, we are saying please select all that apply, and then I can submit. And the portal is informing me that it is finished, and now it's redirecting me to the portal. So in reality, it would be 5 weeks before the next survey is available to me, but for these demonstration purposes, we remove that delay. But in a production mode, it will take 5 weeks for the patient, by logging into this portal by invitation, can see the second survey. Right now, I am going to log out as a patient and log in as a doctor, where I have created an account already. So here we are. You can see my tablet already remembered me. I'm logging into the ecosystem. Now there's more information, more types of surveys available to the doctors, but first I have to select my patient. Joy Doe has selected me as a doctor. That's why I can see that information. I can, for example, pre-examine what the patient has already filled in this bottom survey, which says patient stress urinary incontinence survey. Examine what the patient has entered. Or I can go back to my dashboard and select my own part, which is surgeon questionnaires. For example, I can come preoperative questionnaire. This is on surgeon's part. Obviously, I can see the information that patient has entered about their demographics. Those are the boxes where blue highlights exist. And then these are my part as a doctor. So I can fill in my own questionnaire. Okay, you see it's a very fast procedure. I mean, I'm just reading and clicking around. Obviously, somebody has to think about some of these things when they're filling the real one. Okay, you see, and there are conditional logic. So if I say yes, there are more questions. If I say no, there are no more questions. And here we have different types of constraints. You can have dictionary constraints, you can have range constraints, etc. So if there are questions that are not answered, the interface will highlight in blue, in red. Okay, and that's actually another validation. I intentionally missed the field, and then it warned me that I have to make a selection, which means the records are validated before they are submitted. The moment I fix in all errors, now I am redirected to my main dashboard. So this is the demonstration on the doctor's side. So also we implemented experience surveys. Not only we can go and fill in the different surveys as time triggers and dependency triggers between patient and doctor, but also we can fill in usability questionnaires. And this is what we have done, a test with patients and doctors, where we can choose different, which device did I use, was it clear for me, what other changes were supported, etc. And then we can save this also. So that will allow us to improve the interface in the future and kind of make the system more robust and more usable for the future patients and doctors.
Thank you, Vahan, for that demonstration. So now I'm going to go over the pilot that we ran here at Cornell with approximately 20 patients and 5 providers. Overall, patients felt that the experience was, they rated it a 9 out of 10 for using the mobile app device. 100% of the patients found the questions understandable, 95% found the layout convenient, and 100% found the text, colors, and the contrast effective. 2/3 of the patients found the interface intuitively clear, and 95% did not need help to complete the surveys. Over half the participants were interested in to replace their in-person visits with our mobile app. From the provider standpoint, we had 5 providers review the device. Overall, they rated their experiences an 8.6 out of 10. 100% found the questions clear and understandable. 100% found the layout, text, colors, contrast effective. 80% found the usability clear, and 80% were interested in replacing their in-person visits with this. Next slide. Overall, when we look at the limitations of administrative data sets and retrospective studies, patients frequently are lost to relocation, changes in insurance status, changes in the EHR system, subsequent visits that are non-surgical, such as bulking agent, vaginal estrogen that's given in the office, use of pessaries, are lost. With this mobile app, these factors no longer bind the data. And as a result, because of this digital platform, its ease of access and its usability, we're able to capture these events. And now Anne's gonna continue the presentation.
Thank you for the opportunity to share some comments here today about the importance of the nature of the work that you've heard about. Our mission at CDRH is to ensure that patients have access to safe, effective, and high quality devices. And we recognize that in order to do this, we need to ensure that patients are at the center of our decision-making process. One way to do this is by encouraging the inclusion of patient-generated data like patient-reported outcomes that you've heard about today in the evaluation of medical devices. Patient-generated data has a number of benefits in the regulatory context. It can help us to inform clinical trial design, identify specific subsets of population views on benefits and risks. It can answer questions we might have around specific challenges and patients might be having with devices. And it can also help us to recognize new considerations and adverse events that aren't reported elsewhere. Next slide. In terms of regulatory submissions, CDRH sees the inclusion of PROs as entirely voluntary, but to be useful in device evaluation, they need to be fit for purpose. That is, their level of validation needs to be sufficient to support their context of use. Some of these would include study eligibility, so determination of who should be included in this clinical study, safety endpoints, determination of the safety of the device in terms of symptoms and function, and effectiveness endpoints or measures of the effectiveness of a device in treating or diagnosing a certain condition. Next slide, please. And today's presentation is timely as CDRH just recently released a new draft guidance document titled Principles for Selecting, Developing, Modifying, and Adapting PRO Instruments for Use in Medical Device Evaluation. This includes some background information on principles to be considered when incorporating PROs into regulatory submissions, recommendations about PROs being fit for purpose, and some best practices to ensure PROs meet requirements for consideration. The project we heard about today is a prime example of how CDRH regularly collaborates with external stakeholders to advance the development and validation of PROs for regulatory use. And we hope to continue to do so to promote the inclusion of the patient voice in evaluation. Should you have any questions for CDRH, there is an email at the bottom of this slide where they can be addressed. And I'd like to thank NESTcc for inviting us to be part of today's panel and involved in this work. Thank you. And now we'll take some questions from the audience.